happened to be pretty grim. And that message sounded like eat this bland diet, take this blood pressure pill, and hope your numbers don't get worse too fast. Now, tonight, I want to make sure you understand that that playbook is absolutely dead. So, I know many of you guys are watching from around the world right now, and you might have chronic kidney disease or CKD, or maybe someone you love does, and you want answers. So today is all about giving you the answers that you want. So I want to welcome back everyone. I'm Dr. Sean Hashmi. I'm a board certified nephrologist and obesity medicine specialist. And for this AMA, I spent the last 2 weeks analyzing the data from the biggest medical conferences of late 2025 and up until now, early 2026. And what I found, I really feel changes everything that you want to understand. So let's go ahead and dive in. First thing is of course, I just want to remind everyone, if you're new here to the channel, please hit that subscribe button because I do try to spend a lot of time sharing evidence-based health tips with you guys every single week with the goal of helping you protect your kidneys and your metabolic health. And if you can, tap that subscribe button right now. It's free and it helps everyone to be able to find this information, to continue to share this information. All right, let's talk about the 3 shifts. So tonight, I'm going to walk you through the 3 major shifts that are happening right now in medicine. Number 1 is the kidney shift. The FDA has just approved a drug for kidney protection that you probably think is just for weight loss. Plus, we finally have proof that fiber is medicine, not a danger. Number 2, we're going to talk about tonight the metabolic shift. There's new data on meal timing and the complex relationship between your brain, your muscles, and the new weight loss drugs. And then number 3 is the longevity shift. We're moving from lifespan to health span. Your kidneys may actually hold the key to slowing down your biological clock. All right, why does this all matter? So let me put something in perspective about chronic kidney disease. 37, that's right, 37 million Americans have chronic kidney disease. That's 1 in 7, and most don't know it. Now, if you're watching from the United Kingdom, from India, from the Philippines, from Nigeria, the numbers are just staggering for you. CKD, or chronic kidney disease, is a global epidemic. Now, for decades, nephrologists played defense. We played not to lose. But now it's 2026, and I can tell you that for the first time, we are playing offense. No more defense. We now have drugs that protect kidneys. We have precision therapies for autoimmune kidney disease that we're going to talk about. We even have early data on regenerating kidney tissue. So, here is what's remarkable. The drug that you take for your kidneys, turns out, might also extend your life. The diet that heals your gut can also filter out your toxins. Everything you're going to find is absolutely connected, and that's the theme for tonight. As always, I just want to remind everybody, this is education. This is not personal medical advice. I know a number of you asked me specifically about your medical condition. As you know, I am not allowed to be able to give you medical advice specifically to your condition because that's a doctor-patient relationship, and that's something you have to do formally. Can't have somebody on the internet giving you advice. So remember, I try to give you information based on the research. I give you the references so you can have that discussion with your own doctors. All right, now grab a notepad. You can always watch this later, but grab a notepad, take some notes. Let's get started. Okay, now, of course, before we dive in, I want to make sure that I want to hear from all of you. So I always ask this question. If you're watching live, Drop a comment right now. Let me know where you're from. I love hearing this part. And in the past, we've had people coming in from London, from Dubai, from Manila, from Lagos, from Toronto, from Karachi, from Sydney. So wherever you are, let me know in the chat right now, where are you guys logging in from and what kind of brought you over to this thing tonight? Because as I see all of these folks who are putting it in the chat right now, I want you to know this is why I do this. Evidence-based health education, it really shouldn't be locked behind a paywall or a zip code or whatever it is. To my members who are watching this, by the way, I just want to thank you so much for supporting this work. Your support really is what keeps this content going free for everyone. And if you're not a member yet and you want to support this work, just tap that join button next to the subscribe button. Remember, every membership helps me to keep making these videos. All right, enough about all of that. That's not why you came here. So let's dive into the research for tonight. So the elephant that's in the room, Ozempic, Wegovy, Zepbound, Mounjaro, these GLP-1 and GLP-2 receptor agonists. For the last 3 years, the media has talked about these as vanity drugs, celebrity weight loss secrets. But while the tabloids, they were talking about swimsuits, kidney doctors like myself were watching a clinical trial called the FLOW study. Now, this was a massive study. There were over 3,500 patients. All had type 2 diabetes and chronic kidney disease. They were put on semaglutide, which goes by the name of Ozempic and Wegovy, and the study was stopped early. Why? Well, because it was unethical to keep the placebo group on the placebo. The drug, the treatment arm, was just working too well. The data showed a 24% reduction in the composite of kidney failure, sustained kidney decline, and heart death or cardiovascular death. On January 28, 2025, the FDA approved Ozempic as the first and only GLP-1 for kidney protection in patients with type 2 diabetes and chronic kidney disease. And this is truly historic. Now, let me explain to you why it works so you don't think this is magic. When you have diabetes or obesity, your kidneys experience something called hyperfiltration. So the best way I can describe this is, imagine your kidneys are like coffee filters. If you pour water through them gently, they're going to last forever. But in diabetes, the pressure is cranked up. And so it's like blasting that filter with a fire hose. Now, the filter works great for a while. In fact, it actually works too well. But then it tears. And that tear in that kidney filter is the kidney damage. So GLP-1s like Ozempic, they don't just lower blood sugar. They reduce the glomerular pressure, the pressure on the kidney filters. They turn down that fire hose. And they may reduce inflammation in the kidney tissues themselves. So if you have type 2 diabetes and chronic kidney disease, and your doctor says, well, your weight is okay, so you don't need Ozempic, remember, that's old school thinking. In 2026, these drugs are what I call the kidney shield. So my challenge to you, ask your doctor, am I a candidate for a GLP-1 for kidney protection? Ask, especially if you have diabetes and kidney disease. Now, drugs like GLP-1s, remember, they are great for slowing things down. But what if we could treat the actual root cause? Let me give you an example of this. Let's talk about IgA nephropathy. Now, what's so important about IgA nephropathy? Well, this is the most common autoimmune kidney disease in the world. So for decades, when it came time for treatment, we treated it with high-dose steroids. We basically nuked the entire immune system. What was the result? Patients got weight gain, bone loss, infection risk, even higher cancer risk. But now we have what we call precision therapy, precision medicine. In this case, it's precision immunotherapy. So there's a drug called sibeprenlimab. I don't know how they come up with these names. Whoever does, they make them so hard to pronounce. But this just got FDA approval. And instead of throwing in a nuclear bomb, you have a sniper rifle. So here's the science. In IgA nephropathy, the problem starts with a molecule called galactose deficient IgA1. I have a whole series on the channel where I go into details about this. It is an abnormal antibody. And this antibody, what it does is it forms these immune complexes and they deposit in your kidneys, and guess what? They cause inflammation. And the molecule that drives the production of these abnormal antibodies is called APRIL. So sibeprenlimab blocks APRIL. The phase 3 visionary trial, it's published in the New England Journal of Medicine, it showed a 51% reduction in protein in the urine at 9 months. 51%, that is absolutely remarkable. So if you have IgA nephropathy, you want to talk to your nephrologist about whether APRIL targeting therapy is right for you or not. Now, let me get a little bit futuristic for a second. There's a company called ProKidney, and it's running a phase 3 trial on something called renal autologous cell therapy. I know it's fancy words, but let me explain to you what it is. First of all, the product is called rilparencel. Rilparencel. And here's the process. Step number 1 is they biopsy your kidney. Step number 2 is they isolate the healthy kidney progenitor cells. Step number 3 is they expand these cells in a bioreactor. And step number 4 is they inject them back into your kidney. So the idea is simple. You're trying to reseed the kidney with healthy workers. Their phase 2 data showed that there was a 78% improvement in the annual rate of kidney function decline in one of the study cohorts they did. Now, before we get overly excited, I want to be clear. This is still in clinical trials. Some of the phase 2 results were mixed across different dosing groups, and phase 3 study data won't be available until 2027. But the concept of regenerating kidney is no longer science fiction. It is in active clinical testing right now. Just like if you joined me last month, we talked about pig kidney transplants and how the study has officially started last year in December. Okay, now let's take a breath. These were drugs and procedures, lots of fancy language, but you're probably wondering, that's fine, but wherever I am, what can I do tonight as I'm watching this? Well, let's talk a little bit about what can you do tonight starting at the grocery store. Now, I want to address a myth that has hurt kidney patients for decades, the fear of potassium. Remember, the old school advice was, don't eat oranges, don't eat tomatoes, don't eat beans because they all have potassium, and high potassium stops the heart. That's true, but that advice, it led to patients eating white bread, white rice, boiled chicken. But here's where it becomes really important. There's a study from the University of Wollongong in Australia. It was published in the Clinical Journal of the American Society of Nephrology. And this challenged this old school thinking head on. They put chronic kidney disease patients on a high diversity plant-based diet. What was the goal? 30 different plant foods per week. So what did they find? patients who had more advanced kidney disease and higher baseline toxin levels, they saw meaningful reductions in their uremic toxins. The diet also shifted their gut microbiome towards making more healthy compounds, things like butyrate. Now, this is important because on top of all of this stuff, they didn't notice any significant electrolyte disturbances. So, in other words, they didn't notice that the patients in this study, their potassiums were skyrocketing. Now, I want to be transparent. This was a small study, 25 patients, and the toxin reduction was not consistent across every participant. But the signal is clear and it aligns with a growing body of evidence. So, let me explain uremic toxins. When you eat a lot of meat, your gut bacteria, it converts the amino acids into toxins like p-cresyl sulfate, indoxyl sulfate, and your kidneys have to filter these out. So if your kidneys are damaged, these toxins build up, they make you feel sick, tired, and foggy. On the other hand, when you eat fiber, your gut bacteria changes. They stop making toxins and they start making something called short chain fatty acids. These short chain fatty acids have anti inflammatory, they have barrier protective effects, and they help protect the kidney. So, here is the 30 plant challenge. Now, don't get scared. I know 30 sounds like a lot, but I'm not asking for 30 servings. I'm talking about 30 types. So, for example, if you have morning oatmeal with chia seeds, flax seeds, and blueberries, guess what? That's 4 points. A salad with lettuce, cucumber, tomato, onions, walnuts, that's 5 points already. Bean chili with kidney beans, black beans, peppers, garlic, and onion, that's another 5 points. So you see, you can hit 30 in a week without even trying that hard. What's the bottom line here? Unless your potassium is dangerously high and your doctor specifically told you to restrict avoiding plants, make sure that you understand if you're just avoiding plants, you may actually be hurting your gut, which in turn can damage your kidneys. And so the idea here is that fiber is the filter when it comes to your kidney health. Now, let's switch gear and go out of the kidney update and talk a little bit about the engine of the body, our metabolism. We've been arguing about diet for decades: low carb, low fat, keto, vegan. And the biggest recent debate: intermittent fasting. The question comes up with intermittent fasting is it just a myth? Is it that fasting works? Or is it just that the act of fasting really is calorie cutting? So, what's the evidence? Not some guru on Instagram, their opinion. Here's what the evidence shows. There are multiple randomized studies that have shown that restricting your eating window can improve insulin sensitivity, reduce visceral fat, even when total calories are held constant. So, comparing weight loss, even though the weight loss may be identical with cutting calories or with intermittent fasting has all these secondary benefits that are actually very, very powerful. There's a Nature Medicine trial in pre-diabetics which showed that early time-restricted eating, it actually improved postprandial, meaning after eating sugar, at 6 months. So in other words, folks who did early time-restricted eating, meaning eating earlier in the day when the sun is up, stop eating when the sun is down, their ability to be able to get their blood sugars lower after eating was better at 6 months. Now, I need to give you the full picture. So there's a late 2025 trial. It was in Science Translational Medicine, and it found that isocaloric, meaning same calories, time restricted eating, without trying to cut calories, it did not improve your cardiometabolic markers in women who were overweight. So, if you're a little bit confused, understand you're not the only one. The evidence is mixed. So, what is the take home on fasting? Well, in my humble opinion, the benefit for fasting comes from a combination of a reasonable eating window plus the natural cutting of calories that follows. So, it's not just fasting, it's fasting and eating less. Think of your metabolism, it's almost like a factory. So remember, when you eat, the factory is in production mode. It's building, it's storing, it's processing. But when you stop eating, the factory switches to cleaning mode. It sweeps the floors, it fixes the machines, it takes out the trash. So if you eat breakfast, let's say at 7 a.m., and you finish eating at 11 p.m., your factory never closes. It never gets a chance to clean the floors. So I want to give you an actionable step. I'm not going to ask you for some crazy fast, like a 20-hour fast that some people talk about. I'm going to ask you for something very basic. Start very reasonable and try to keep your eating when the sun is up. So ideally, stay under 12 hours for an eating window. If you watched all the videos I've done on intermittent fasting, I talked about the ideal window being 6 to 10 hours. But even if you stick to 12 hours, it's a wonderful goal that is doable, achievable, and sustainable. So try to finish your dinner at 7:30 p.m. and close the kitchen. Don't open it till 7:30 in the morning. That's a 12-hour break. It's achievable, it's sustainable, and this becomes a very simple metabolic tool that you can have that doesn't cost anything at all. All right, let's go into another topic. I want to circle back to us talking about GLP-1s. Now, there is a crucial nuance that you really want to know starting in 2026, and that specifically is about the brain. Remember, we used to think about obesity as it's just a willpower issue. People are lazy. That's why they overeat. Why can't they just put the fork down? Why don't they just eat less and move more? Well, these drugs have proved that obesity is a disease and it's about signaling. There's observational data coming out that's showing now that GLP-1s actually reduce what we call food noise. And food noise is that obsessive loop that we go through in our head about what we're going to eat next. We keep thinking, what are we going to eat next? And we are also seeing associations with reduced substance use behavior. So there's a large cohort study from Wang, Volkov, and colleagues, and this was published in Nature Communications. And what they found was that semaglutide, which goes by the brand name of Ozempic and Wegovy, semaglutide use was associated with roughly a 50% lower risk of new alcohol use disorder diagnoses. Now, think about that for a second. That's extraordinary. However, there's also signals that are coming out regarding depression and anxiety in some people. In some people, they're reporting their depression is better, their anxiety is better, but in others, depression is actually getting worse. So remember, for some people, if you quiet that reward center, you can actually make them feel flat, joyless. So if you start these drugs and if your mood starts to dip, please do not ignore these signs. Stop the drug, call your doctor immediately so you can figure out what the next steps you could do. The next piece on this is the muscle. Remember, this is the biggest risk for kidney patients. If you think about what happens here, the risk that we're talking about is sarcopenia. So when you take GLP-1s, you lose weight fast, but research suggests that up to 30 to 50%, so almost half the weight that you lose can be coming from muscle. And that muscle, of course, can also make some bone loss. So, kidney patients, especially our dialysis patients, are already prone to frailty. So, if a drug strips your muscle, you might save your kidneys from diabetes, but you may end up too weak to walk upstairs, God forbid, have a fall. So, what's the prescription that I'm recommending? If you've been prescribed Wegovy or Ozempic, you also need a prescription for number one, adequate protein. Remember, you want to talk to your kidney doctor and your dietitian to find out what is the right amount of protein for your stage of kidney disease based on where you're at, how much protein you're spilling, and more information that makes it personalized. Try not to get generic advice from anyone on the internet, including yours truly. My goal is always give you the tools so you can take those back with you. Remember, this protein advice is different for everyone. Number two is resistance training. You have to lift heavy things, period. Now, if you say, look, doc, I can't afford a gym, I'm going through a lot of stuff, that's fine. The simplest thing you can do on your own is sitting in a chair, no wheels, of course, because you don't want it sliding, and standing. That's called a squat. Now, do that 10, 15 times every single day. You are working the biggest muscles off your body and strengthening them. That's your leg muscles. Remember, as much as we want to talk about a gun show or show off your biceps, biceps are not the main muscles. It's the big muscle groups, legs, chest, back. Those are the muscle groups that we're talking about. And keep in mind, you have to earn the muscle that the drug tries to take away. And you're going to earn it by resistance training. All right, let's go into the next topic. So far, we've covered the organ, we've covered the engine. Now let's shift gears and talk about the timeline. So let me ask everybody on the call today, how old are you? And I'm really curious. You don't have to say your actual age. You can make up a number. That's fine. If you don't feel comfortable, don't feel pressured. But how old are you? And I want to tell you, as you're answering these and putting these in the chat, keep in mind, most of you will answer based on your birth year. And what I would respond to that is, you are giving me the wrong number. That's your chronological age. In other words, that's the number of times you have orbited the sun. But your body doesn't care about the sun. It cares about your biological age. We are now in the era of epigenetic clocks. So imagine your DNA is your operating system. And over time, it picks up scratches, glitches, and rust. And that rust is called DNA methylation. Now, we can measure it with a blood test, but research from multiple institutions has shown that this biological rust can actually predict stroke and dementia far better than your birthday does. So, why is that good news? Because you can't go back in time to change your birth year, but you can get rid of the rust. You can scrub the rust. So studies show that plant-based diets, meal timing, stress management, exercise, social connection, gratitude, kindness, or the self principle, these are associated with slower biological aging and more favorable methylation patterns. We're not talking about some crazy supplement here. We are moving to a world where, once again, anti-aging is not about looking 20. It's about having the biological resilience of a 40-year-old when you are 70. Think about that for a second. Now, let's get into the most exciting concept, which is longevity science. Now, keep in mind, there's all sorts of gurus out there that are going to promise you can live forever and all that. All of you who have followed me for years, you know everything I always give you is evidence-based. There's no hype, but I always try to give you hope. I think hope is one of the most beautiful four-letter words that's out there and you need it. So let's talk about senolytics. Remember, as you age, some of your cells are going to get damaged. Usually, your body is going to kill them, and that's called apoptosis. So, apoptosis is essentially getting rid of those damaged cells. But some of those damaged cells, they survive. They stop working, but they don't die. They just sit there. And we call them senescent cells. Senescent cells, or if you want to make it simpler, they're zombie cells. They're not doing much, just secreting only inflammatory signals. So they're essentially toxic and they infect all the healthy cells that are around them. And there are two key strategies to deal with them. One is senolytics. Senolytics are drugs that kill zombie cells. The other one that's quite important is xenomorphics. Xenomorphics are compounds that quiet the inflammatory signals that zombies produce. And here's the big reveal of tonight. If you're a kidney patient and you've been listening to me, you might have already been taking a xenomorphic. Which one is it? Well, those are the SGLT2 inhibitors, names like Jardiance, Farxiga. Remember, we have known for years that SGLT2 inhibitors, they protect the heart, they protect the kidneys, but the NIA interventions testing program, what it found was that canagliflozin, it extended the lifespan in male mice by about 14%. Now I know what you're thinking. Mice are not humans. Agreed. But remember what we're talking about. Taming the inflammatory signal. And SGLT2 inhibitors have already been shown to do that in kidneys, in heart. So there's a 2024 study in Nature Aging, and it showed that SGLT2 inhibitors, they enhance immune-mediated clearance of senescent cells. So as you're thinking about this, this is not a single data point from some random study. This is established, peer-reviewed research that's being replicated and building over time. So in humans, SGLT2 inhibitors already improve survival and major kidney and cardiovascular outcomes. The mouse data suggests that they may also act through aging biology pathways. So what's the grand conclusion? The drug that you take for your kidneys may actually be a longevity drug. Once again, no hype, just hope. So the drug you take for your diabetes is what I call a kidney shield. The diet you eat for your gut is a uremic toxin filter. So if you're listening, see how everything that I'm talking about tonight, everything is ultimately connected. So, what is the bottom line here? What can you do with all this information that we talked about tonight? Let me give you a checklist for your next doctor's visit. Number one, ask about meds. Am I eligible for GLP-1s like Ozempic, Wegovy, Zepbound, Mounjaro, etc.? Am I eligible for GLP-1s or SGLT2 inhibitors for kidney protection? Your homework tonight, count the plants. Don't count the calories this week. Count plants. Aim for 30 types of plants total to eat this week. Go back and listen to the video recording again. Look at all the examples I gave. Number three, watch the clock. Give your body that 12 hours of cleanup shift work every single night. You can go more than that, but remember, I'm asking for 12 hours as a simple, basic starting point. Don't go crazy. Your eating window in studies, the best outcomes were 6 to 10 hour eating window. But start slow and make it sustainable. It's better to have the pace for a marathon than to act like a sprinter, burn out, and go back to bad habits. Number 4, protect the muscle. If you're losing weight, lift heavy things. Remember, science is moving faster than it ever has before, and my job is to keep you ahead of that curve. Now, if this helped you out tonight, hit that like button, hit that subscribe button, because I really spend a lot of time to bring you evidence-based health tips every single week. And if you want to support this work, hit that join button next to the subscribe button. Remember, your membership really helps to keep these videos free for every single person. Now, drop your questions in the comment section, because I'm going to go through every single one of your questions that you guys have been asking. And I want to stop by saying to everyone watching from around the world and from every time zone, I want to say thank you. Thank you so much. And as always, practice kindness, practice gratitude. Thank you so much for watching. And let's get into the part that I know all of you guys are here for, which is the Q&A. So if you got questions, now is the time. Start popping them in the chat. I'm going to start from the very beginning. Wow, I do see the chat is filled with questions. So let's start grabbing some questions and go through them. Okay, so bear with me here, because I'm going to start to look at all the questions you guys have been asking. So first question was, Dr. Hashmi, I have kidney cysts, stage 2, my creatinine is 0.66, potassium is 3.2, alk phos is 44, GFR is 91, total protein is 6.7. My doctor doesn't seem to be worried. Should I ask to see a kidney doctor? So here's the thing about that you want to know. First thing, let's start with kidney cyst. So with kidney cyst, they're simple cyst and they're complex cyst. And you want to know if they're complex cyst because there's stages to it. Even with complex cysts, most kidney cyst, we leave them alone. But if it's a certain thing where the walls are getting thicker and there's suspicious things, then we will actually have you see a urologist to talk about what your options there are. So that's number 1. Number 2 is if your kidney function, depending on what your age is, some people might find that they easily get placed into a creatinine or eGFR that makes it look like they're stage 2, and they get very nervous. But if you don't have risk factors, diabetes, high blood pressure, if you don't have excess weight, if you're not spilling protein in the urine, then by definition, without protein in the urine, you don't actually have CKD2. So just keep that in mind. All right, let's see a couple of comments over here about meloxicam. Someone talked about hyperfiltration. Here's a question. Hi, doc. I'm from Philippines. Wow, welcome all the way from the Philippines. The microalbumin is 10.3, taking dapagliflozin. And is it okay to drink 1 can of beer per night or 1 standard drink? So let me tell you my stance on alcohol. Now, this is my stance having read thousands and thousands of papers over decades. I don't think there's a single redeeming value. I don't think there's a single redeeming value to alcohol. Now, I get it. Some people might like the taste and so forth, but beyond that, there isn't anything healthy about it. So the safest alcohol is 0 alcohol. And the thing about alcohol is for example, in people taking GLP-1s, there is a risk for pancreatitis. And pancreatitis can and will kill you. Every drink of alcohol is causing a little bit of cells in your brain to die. So once again, I'm not saying don't drink it, but if you said, what would you do? What would be your advice to your family members? It would be that there is no safe alcohol drinking limit. All right. Someone said, anybody else frozen? I'm so sorry if the video froze. My apologies. I have somebody from Vancouver. That's amazing. And I actually have somebody from Los Angeles, so in my neighborhood. I'm actually out in Orange County. Got some people here from Ohio, California, Montreal, Florida. This is so cool. Well, thank you so much for joining, guys. This is absolutely amazing. So I appreciate it. All right, let's see. Australia, Pennsylvania, wow. Puerto Vallarta, Mexico, Georgia. Let's see. Los Angeles, for my family member. This is, I hope that these kind of lives help you guys out, because that's always my goal, is not to talk like I know everything. I don't. I try to study the research so I can present it to you simply. You all know my story. When I was coming up, I wish there was a doctor that took a couple of extra minutes to explain things, because when my sister was ill, that was the one thing that I would have given anything in the world to have, was once again kindness, and just somebody who wasn't trying to make a buck from me, but trying to explain things. Got somebody here from India. All right. Let's see. Would an admin or somebody please enable the closed captioning? I have to apologize. YouTube, the way it works is it has a lag. So when you do these lives, you can either have it have low latency so I can see what you guys are saying, or I can turn on captions. So one or the other. So if I do the low latency, then it makes it harder for me to connect with you guys and answer your questions. Okay. Massachusetts, wow, had a right radical nephrectomy 1 year ago due to cancer, trying to protect the remaining kidney. So remember, what you put on your mouth is incredibly important. A predominant whole food plant based diet has so much data. This is not political. It's the research shows that the more plants you eat, the better off your kidneys are going to be. And thank you, Dr. Hashmi from Los Angeles. You are very welcome. We got some South Carolina here, got more Canada here. That is amazing. Let's see, someone here who had a type 2, I'm assuming type 2 diabetes, had a Roux-en-Y gastric bypass in 2011. CKD3, GFR53, also had a radical nephrectomy in 2024, is on Manjaro. So once again, Manjaro is what I call a GLP-2. So what's a GLP-1? It's one agent, semaglutide. GLP-2 is two agents. In this particular case, you're looking at a GLP-1 and another agent with it. So GLP-1, GIP. And so that's what I call GLP-2s. Now there's GLP-3s that are coming out as well very, very soon. So you want to know about it. And of course, with GLP-1s, the oral versions have just come out. Now keep in mind, the real world data shows that oral semaglutide isn't working as good as the injections do. Why? For several reasons. With oral semaglutide, the challenge there is 90% of it gets just broken down really, really fast by your stomach acid. So that's why you'll see the dosage is like 25 milligrams versus the injection, the dosing is like 2 or 2.4 milligrams. That's number one. Number two, what you want to know about it is the injections have a very smooth curve for 7 days. But with the oral one, you're taking it every single day, so you have a peak and trough every day. So in the real world, what the patients so far, if you go to sites, you'll see the feedback, they're saying they don't get the same appetite suppression. Now, in the studies, which is a very controlled environment, the difference was 15% weight loss for injections, 14% for the oral pill. But with the Wegovy oral pill, I think the jury is still out. So injections, in my humble opinion, as of now, I think they're still better than the oral versions are. Someone said, and like with the vax, side effects haven't been exposed. So there's a lot of things that we've learned. We've had metformin first discovered in 1919. It's the extract of the French lilac flower. We've been using it forever. And just recently, we've discovered certain things, good and bad, that we're just finding out. That's after 100 years of studying it. So keep in mind, we will never know all the details. And that's why you always want to work with your doctor and have a relationship so you can make that decision together. We got somebody here from Karachi, Pakistan, Northern California, South Africa, beautiful. And let's see, someone said, love your presentation and the way you explained so clearly. Well, thank you so much for doing that. And this person is a subscriber, so thank you for supporting this channel as well. And regenerating kidneys, wow, yes, yes, right? This concept of us being able to regenerate kidneys, how incredibly powerful is this? This is just beyond belief. And someone said, can you talk a little louder? So my apologies if you guys couldn't hear. I tested my mic, so I'm so sorry if it was too soft. And let's see, another person from Southern California. I saw your ages. This is incredible. I mean, we have all different types of ages from 19 years up to 80 plus years. Bless all of your hearts. How incredible is that? And by the way, how cool is that? And how lucky am I that you guys, in all your different time zones, decided to spend an hour of your evening, morning, in the middle of the night with a guy like me. So thank you. That really means the world to me. Someone said that they've been eating a plant-based diet for a while now. That is amazing, good for you. And remember, plant-based diets, once again, have so much benefits in there. Someone said, sir, what if DAPA use results in huge weight loss in just 5 months? So that's rapid weight loss. When you're having that, you want to talk to your doctor, because part of that is we want to make sure there isn't anything else that's causing it. Dapagliflozin, which is an SGLT2 inhibitor, doesn't cause a whole lot of weight loss. So if that's happening, we need to investigate and find out why that's happening. So please check that out. Someone said hello from Arizona. Well, hello back. So how far are we from generic GLP-1 and SGLT2? Well, remember, SGLT2s have gone generic already, so we do have empagliflozin. But as far as GLP-1s go, no, the patent is going to go, at least in the United States, until 2032, I believe. Don't quote me on the exact number. It might be 31 or 32. But in other countries, the Ozempic patent should be coming off. But keep in mind, Victoza, which is a GLP-1, has already gone generic. It's a daily injection. Not as strong as Ozempic is, but it's already gone generic. All right, is it GLP-1 drugs bad for your vision like Ozempic? So when it comes to vision, the risk of Nion that I spoke about in several videos is extremely low, but it's there. And it was seen mostly in poorly controlled diabetics. So if your A1C is really high, 10, 11, so forth, you really want to get that controlled before just jumping straight onto the GLP-1s. The thought process was that a rapid decline in your blood sugars would cause a rapid decline in the blood flow to your eyes, and that's what would create the damage. Another question was pre-diabetes with IgA nephropathy don't qualify for GLP-1s unless their blood sugars get worse. What about SGLT2s for pre-diabetic range? Love the numbers for the menus. Okay, so when it comes to pre-diabetes, if you have it, keep in mind that metformin is a great drug to be able to use. It's got a little bit of weight loss. It can improve the insulin resistance. Healthy eating can make the biggest difference. Exercise can be like turbocharging whatever you're eating. So you don't need to jump directly into drugs as the first line. See if your sleep is good. See if your exercise is good. See if your diet is good. But most importantly, don't forget the stress in your life. And keep in mind, I know it sounds like mushy stuff or cliche, but kindness and gratitude. I say this a million times, and I think I got to say it 10 million times. But kindness and gratitude, the ROI or return on investment to you is so great. It's so great that the greatest way to be selfish is to go do a random act of kindness for somebody and not expect anything in return. It will lower your cortisol, lower your blood pressure, improve your blood sugars, improve your insulin sensitivity. It will literally cause you to improve your health span and lifespan by doing a random act of kindness for somebody where they didn't need it, without expecting anything in return. So me doing these episodes for you guys, that's me being selfish. And that's the message for you as well. All right. Someone said, thank you. Well, you are very welcome. Someone said, my EGFR improved from 19 to 35. Plant-based, life changes, and a new nephrologist. Well, first of all, how incredible is that? Congratulations. I'm actually writing a book right now. It's the Kidney Resilience Blueprint, and I'm talking about the journey of some of my patients and how they improved their GFR by making these changes. Someone asked the question, hello, doctor, your opinion on increasing SGLT dose from 10 to 25 milligrams for healthy individual for longevity, combined with adding metformin to push A1C from 5.7 to 5.1. So remember, every drug has side effects. Yes, it will help you with benefits, but there are side effects. So that's why we don't just blanketly say, okay, well, you got a little bit of prediabetes. Let's go ahead and add on some Jardians. Because Jardians, as you know, what are the side effects? Well, one of the main ones is it can cause very nasty infections down there, urinary tract infections, but more seriously, fungal infections. It can also cause metabolic acidosis. So Jardiance by itself, because it's making you pee out sugar, it's not without risk. And that's why always think about, before you jump on this stuff, always think about the idea that have I done everything? Someone asked the question of how can I find a good dietitian? You know, finding good dietitians is always hard. I, of course, worked with Michelle Crosmer, who's my partner. We used to have a YouTube channel, and, you know, we've been busy with life and so forth. But, you know, there are lots of incredible renal dietitians out there. And if I find out some names, I will absolutely be certain to put them up there. All right. PCSK9 inhibitors in traditional Chinese medicine include berberine, curcumin, resveratrol, quercetin, ginkgo, and these are generally safe when taken in moderation. So, yes and no. And let me tell you why. The biggest problem we're starting to run into is standards on how the supplements are being made. What you'll find, for example, there's been a number of cases of liver injury with curcumin or turmeric. Turmeric, as you know, I was born in Pakistan, and there we cook with turmeric all the time. But when you get it in a capsule, it can be laden with all sorts of heavy metals, and that can become a huge issue. On my Instagram page, if you follow me at Sean Hashmi MD, you'll see that I shared the report from Florida about how a lot of the kids' candies were tainted with things like arsenic. Your kids should not be eating arsenic. So the answer is yes, those agents are helpful, and finding a reputable brand that's third party tested is incredibly difficult because it's very expensive for these supplement companies to do third party testing. And that's why you want to make sure. Number two is some of them that I see on major websites, they do third party testing in the sense that they tested one batch years ago and they still show the same certificate. So they're not doing ongoing testing of batches that are coming out. So then that's not very helpful either. So yes, I agree with you. And please, please, please just be careful as you're going through that road. Can you take the new IgA Neph drugs when you are in stage 4 CKD? It really depends on all your markers, how much protein in the urine you have, what exactly your GFR number is. What's your ultrasound looking like? Is your kidneys already shrunken so much that it looks like there's already too much damage? So on a question like that, I gotta apologize. You do want to sit down with your kidney doctor. If that's me, then we would sit down together, go through all your numbers, and figure it out. All right, someone asked the question of Ozempic or Jardiance better for thin basement membrane disease. Remember, if you're talking about thin basement or anything else, if you're spilling protein in the urine, what we're trying to do is lower that. So SGLT2 inhibitors are great for people who are spilling protein in the urine. They're going to tame down the inflammation. Ozempic or GLP-1s have not been studied in all the other kidney conditions. So right now, the data is really around diabetes and chronic kidney disease. Now, you could extrapolate that to say, well, GLP-1s lower inflammation as well. So theoretically, they should work as well. And you wouldn't be wrong. But if you wanted me to give you an evidence-based answer, SGLT2 inhibitors, you're spilling protein or not, they're great for slowing down the rate of decline of kidney disease. All right, someone asked the question, over what period should nutrition values be average? A week? That's the basis I've been using, but I can't find any references to time scale. And thanks again, and may God bless you and your family. God bless you and your family as well. A week is wonderful as far as that goes. Remember, sometimes when we first start something, We're so enthusiastic that we want to measure nutrition values so closely. And then we get tired, life happens, and we forget about it. To me, the only reason a week seems like a sweet spot to say that is because it seems flexible. Flexibility in all of this is so important to be able to do it. People are saying that hydrogen water is healing their kidneys. Do you have any thoughts on this? Yeah, I, I looked at the data, and there's some very, very small studies on hydrogen water, and seems promising. But I got to tell you, I haven't found anything convincing where I would come on the air and tell you guys we all got to start drinking that to protect our kidneys. I'm waiting and I'm looking. So save your money, drink regular water. It's the cheapest stuff and it's there and you can have it. Save your money as far as that goes. Now, if that changes, absolutely, I will bring you the research, no problem. What are your thoughts on green smoothie? So, I am anti green smoothies, and I'll tell you why. What you want to do is you want to have your entire digestive system work. When you chew the food, there's a signal from your mouth to your brain that says food is coming in. When food goes in your stomach acid breaks it down. Nature packs all of the nutrients along with fiber, along with water so well that when you blend everything into a smoothie, you're actually making it harder for your body to get all the benefits. You're causing an insulin spike. And this is why even protein powders, you'll see protein powders will cause an insulin spike. Eat your protein, chew your protein. So if you've ever seen me in my weight loss clinic, I tell all my patients, we don't want you to drink protein shakes. We don't want you to take smoothies. They're like, but I love smoothies because they got all this fruit and I put kale and I put spinach and it's healthy. I'm like, great. Eat the kale, eat the spinach, eat the fruit. Nature had millions of years to perfect all this stuff. And then keep in mind, when it comes to those powders, the green powders, you want to make sure that it's not laden with heavy metals because we have seen that over and over again. Third party testing makes such a big difference. So if you're thinking about green smoothies, listen, save yourself some money, eat the fruits and vegetables, and you'll get way better results because of the fact that your digestive system will get to do what it was born to do. And that matters. Let's see. Someone asked a question. I'm having a hard time eating enough proteins from plants. Should I use protein powder? And if so, which one do you recommend? So, this is the ultimate question. Can I get enough protein from plants? Absolutely. Does it take some planning? Yes, it does. Now you have all sorts of tools out there. You can Google it, and Gemini will give you all sorts of ways to get enough protein for your specific size, height, kidney disease status. So you have that. You can take that information, run it by your kidney dietitian or your nephrologist. Make sure you're on the right track because things like Google can hallucinate or make facts up. So you want to make sure it's legit. But keep in mind, you can do that. Also, what I recommend to my patients is look, you don't have to be 100% plant based. Being predominantly plant based is awesome. I call it the 80-20 rule. Be good 80% of the time. And if you do that, you're already ahead of every single person. The thing with perfection is we all talk about wanting to be perfect, but perfection means we're judging people. Stop judging. Let's live our lives. We're on this planet for so short of a time. We blink. I mean, I can tell you, I just realized I'm 51. I know it sounds silly. I just realized that. And it's crazy. I was doing jujitsu and I found out I got two partial thickness tears in my ACLs, right and left knee. It's horrible. I can barely go downstairs. So I had to stop jujitsu. And it was because in my mind, I was still that 20-year-old person who loved doing martial arts and I can't do it. So as far as protein powder goes, no, I would definitely stay away from it. Look at the Consumer Reports article that came out about them testing all these protein powders. I was pretty shocked. And especially on the plant-based protein powders, they were very high in lead, mercury, cadmium, arsenic, and so forth. Do cardio complications, valve replacement, change recommendations for GLP-1 or SGLT? No, they do not, to the best of my knowledge. And then someone said, I have one kidney. The result of a nephrectomy, my creatinine is 1.3, GFR is 50, potassium has now risen to 5.5, temporary on a low potassium diet. That's fine because I understand they're trying to figure out. Next goal is try to see which one or two items were really causing your potassium to go higher. And instead of a blanket statement, cut those down. So work with a dietitian to do that. Someone said they have stage 5 kidney failure and they take the blood pressure pill losartan. Should I get off of it? No, no, because losartan is important to control your blood pressure, even if the kidney function is not there. Blood pressure is really important because when you are on dialysis, you can see that the risk of cardiovascular death goes substantially higher. The only time to go off losartan is if we see that the dose is too high and it's reducing the blood flow to the kidneys too fast or too much, and that's where your kidney doctor comes in. But please don't stop it on your own unless somebody tells you. Let's see, someone said there was a question on tolvaptan. Tolvaptan I talked about a lot for the polycystic kidney disease series. Tarpeo, I have a whole series on IgA. We talked about Tarpeo in there, so you have all of that there. Doctor, my chat was on number 4, but I can't see there in chat. So just go ahead and put your question over in there. You're a self-supporter. You've liked my chat. That's awesome. That's awesome. Well, thank you so much for supporting the channels, for supporting everything that I've been trying to do. Is CoQ10, well, CoQ10 in a general rule, you know, I have very bad migraines. I take CoQ10 myself for all transparency. CoQ10 can be helpful as far as anti-inflammatory goes. In terms of kidneys, though, I don't have a whole lot of data in whether or not that can be helpful. I will look for it, and I'll definitely come back to you guys. Ooh, someone talked about Manjaro had me in the hospital for 9 days with acute pancreatitis after 6 weeks on it. Yes, that is one of the very dangerous side effects of GLP-1s and GLP-2s. In fact, people have even died from it. And so I'm so glad that you're doing okay, and I'm so sorry that you went through it. All right, let's see. There was a comment about celecoxib being 3 times more concentrated in the kidney. And the time is now 7:03. So let me go ahead and do one last question for you guys. Oh, I think I got all the big questions. Let's see, will a pacemaker increase renal perfusion a bit? Yes. So if you have an altered rhythm and you get a pacemaker, let's say you have atrial flutter or atrial fibrillation or whatever it is, and you get a pacemaker that regulates the rhythm, now you're sending regular, good amount of blood flow to your kidneys, and that's going to make a difference. All right, guys, so I just want to go ahead and tell you thank you once again for sticking around. This was an incredible session. And as always, if you found value in this, please share it with someone you think that needs to hear it. And one more time, if you want to support this channel, hit that join button next to the subscribe button on the main page. And as always, please practice kindness, practice gratitude. It's the greatest way to be selfish. I'll see everyone next week in the next evidence-based videos I put up. But once again, it's just a journey. We're on this planet for such a short amount of time. Be kind. I'll see you guys next time.